Good evening to you. Thank you for joining UBC TV. My name is Sophia Matovu, and I'm going to be taking you through this talk show tonight. Proudly sponsored by none other than National Medical Stores. And we are going to be talking about hospice and palliative care, because around the 8th of this month, that's on Saturday. I'm not the expert in this topic of discussion, but let me get to introduce to you the expert panel that I have here with me. Right here next to me, to start with, is none other than Dr. Mwanga Moses, the Assistant Commissioner, Hospice and Palliative Care Services, Ministry of Health. You're most welcome.
Thank you.
And the only beautiful lady tonight is none other than Christine Ebong, Principal Advisory Customer Care Officer from National Medical Stores. Good evening, Christine.
Good evening, Sophie.
Okay.
Yes.
Okay. Next to Christine is Dr. Nasur Boyenza, an academic registrar, Institute of Hospice and Palliative Care. Very good evening to you.
Good evening, Sophie.
And at the extreme end is none other than Mark Donald Mwesiga, Country Director, Palliative Care Association of Uganda. Good evening, Mark.
Good evening, Sophie. Thank you for having us.
Okay. Now, of course, I never take it for granted that when we're talking about this, we are speaking about a topic that's familiar with people. Once we had a very big conference take place in this very same space on matters of palliative care. But I'd like to start by asking maybe Mark, or it could be Dr. Mwanga, to directly tell us, when you talk about hospice and palliative care, what are we talking about?
Yeah, thank you so much, Sophie. Dr. Mwanga, my name. I'm happy to be with you viewers. Palliative care, basically, we are looking at an approach of helping the people and their families for those who have chronic illnesses. So when a person has a chronic illness or a terminal illness, then you come in to help these people. You come in to give them holistic management. You come to give them psychological satisfaction, pain management. Ideally, you give a total quality management of these people who have got a chronic illness. And these people have that illness, you need to improve their quality of life. So when you are there, you're supposed to give them comfort, give them to understand that what they are having as an illness, they can live without it. They can have quality life. The little life they have, they can have really quality life in one way or another. The family also is tortured. Once a person gets a chronic illness, the family needs to understand that this is not the end of life. A person can live. There are people who get cancers. There are also ill, people, when they hear about palliative care, they think these are people who are terminally ill. But these days, whenever you get a chronic illness, things like sickle cell illness, diabetes, hypertension, you really need to understand the illness you have got. So palliative care comes in as soon as a diagnosis is made, and people need to give you reassurance that it's not the end of life. You can survive with this illness. So that's where we come in to give that care, which is a total quality management. You give the treatment as well as giving the psychological satisfaction of that person that you can live with an illness. The family members as well need support to understand that they can support this person in one way or another. So that is what we call palliative care.
Now, when we talk about it, when did it start? When did this kind of services start in Uganda as a country? Because we might be talking about it and somebody's like, but we are hearing this for the first time. We are more used to this routine illnesses and attention that we get in the hospitals. How does one access the services, and when did they start in the country?
I think palliative care started years ago in 1993. It started as a missionary organization. There was a lady, a Mzungu lady by the names of Anna Maria Mann, who started palliative care and started it in Zambia Hospice. But now we have scaled up. It started years back. Palliative care was not very understood in our country. People thought that a person can live with pain. But now as we go along, we have found that all our regional referral hospital, including our national referral hospital, we have palliative care services. Because these illnesses, cancers, hypertension, are everywhere. So you find that these services had to be scaled up. At the Ministry of Health, we have a division of palliative care. And this division is supposed to scale up in all districts to ensure that palliative care is available in all areas of Uganda. The Director General wrote to all hospitals to include palliative care within their services. So palliative care, wherever there is a health facility, palliative care is part and parcel of those facilities. The way we are going, non-communicable diseases are coming on the rise. Because if you look at worldwide, over 56 million people need palliative care. And then you find over 78% of those people are within Africa. Uganda is part and parcel of those 78% who need palliative care. Now, when it comes down to Uganda, you find that many people are having cancers. A few days back, we were discussing about sickle cell disease and the non-communicable diseases. We found that over 400,000 children have sickle cell within Uganda, and all these children need palliative care. When it comes to cancers, we are seeing that there's a rise of cancers within our country. The mere fact that we have a lot of diagnostic equipment coming on board, people can now find easily about their cancers. And as soon as a diagnosis is made, this is when we need to come in with our palliative care. You need to reassure this person that you can live, you can have a quality of life of palliative care. So we have scaled up out of our 18 regional referral hospitals. I think 13 of them have palliative care. Our national referral hospital, Mulago, also has palliative care services. We have trained staffs in palliative care, and we are calling upon all people that you can offer palliative care. Either you're a support staff, you're a spiritual leader, you're a caregiver, you can give care which a person needs to survive.
Okay. Now that brings me to Mark. What is the role of the Palliative Care Association of Uganda, given that he's done a breakdown? There are certain times when the word association is used, some people will look at it in terms of, like, say, if it is a disease, you meet together for psychological support, you know, that psychosocial support, that kind of. Please break it down for us.
Yeah, thank you so much, Sophie, and good evening to viewers once again. And it's great to be at UBC TV with all the panelists here. The role of the Palliative Care Association of Uganda, which is a very good question. The Palliative Care Association of Uganda is the national association for all palliative care providers in the country. Now, when we say palliative care providers, we mean health workers, people that Dr. Mwanga has just spoken about, who are within health facilities. Right now, the Ministry of Health has actually directed, because the Director General has wrote to hospitals, that at least from the national referral up to health center 4, there should be a palliative care service. So we are talking about all those people involved in the care. So the association of these people is what is composing the Palliative Care Association of Uganda. But we don't stop on health workers only. We talk about caregivers. As Dr. Mwang explained, the approach of palliative care doesn't look at the individual who is sick alone, but we look at the caregiver, and in this case it could be anyone. Let's say it's a child, it's a mother, or it's even a mother and the child is looking after. So we look at the caregiver, but we also look at the family. And there's a whole big debate of these days about people who are destitute. They are not actually into formal families, but they have families in their own setting. So we have had teams in the community who have even moved out to look at people, for example, who are on the street. They have a condition that requires palliative care, and who they stay with and who they interact with, because that's their family. So the association has so far 1,300 members who are mainly healthcare workers, and also it is composed of organizations. Now, these are hospices, these are mainly non-government actors, private hospitals, and also standalone hospices, and those are 25. But also we have some caregivers in there. Our work is in two main 5 focus areas. We have been talking about this since the week started, because this is the World Hospice and Palliative Care Week for us as a country. So we do capacity building for our members. We would like to make sure, as Dr. Mwanga has said, that palliative care reaches every district of Uganda. We still have 40 districts without a single health care facility offering palliative care. We would like to reach those ones. We do offer some scholarships for people doing a diploma, a degree, and now a master's level in palliative care. The other thing that we do is research. We want to see that there is evidence for this service that we're talking about. When the World Health Organization says that for every population, 1% will require palliative care, we want to quantify that and put it down and say, these are the people who need palliative care. And we are working with various universities to do that. We also do advocacy. We are putting Dr. Mwanga and the Minister of Health and everybody in government on task. We want to see the National Palliative Care Policy. We want to see the National Strategic Plan for Palliative Care Policy. We want to see the National Standards for Palliative Care Policy. We want to see the ministry take a step from promising and pledging to actually making it a reality. That in every village, the health community teams, the village health teams, when they are training, there is a component of palliative care and referral. And we want to see more awareness. The other thing that we do is governance and sustainability. We are very grateful to the Minister of Health for establishing a division of palliative care. This is unlike before. We often tease Dr. Mwanga that he's the first commissioner for palliative care in Africa, because we don't have any other country putting such a position in that place. Now we need the ministry to move, and now that we have a commissioner, what do we see? Are the services reaching out to the people? Yesterday we had a public lecture at Makerere, and a very strong advocate from one of our partner organizations said, can we see the inclusion of persons with disability? Can we see people who can interpret for people who are deaf into these health facilities? Imagine somebody with a life-limiting illness and with a disability, someone with like a deaf person. They cannot use sign language when speaking to a health worker. The last one that we have been talking about is financial efficiency, and which is also linked to governance. We want to make sure that everybody that is a member of PICAO, be it an organization or an individual offering palliative care, has the level of professionalism, the level of integrity, the level of compassionate care that we talk about, such that this service is sustainable. And of course, I can't stop with that good question without saying that everyone out there who has the heart to be compassionate about people unwell is welcome to be a member of the Palliative Care Association of Uganda. You can join as a life member or as a single individual member, and we are always open and willing to receive everyone so that they join the movement to advocate for palliative care.
Okay. Now I'll get to you, Dr. Nasoro, in terms of picking up from where Mark has left it. Yes. Do we by any chance have statistics and numbers and say, like you'd say, this particular age bracket is what we have noticed that seems to be getting there or getting most of the palliative care? Because there are times people think it is the old, it is strictly people with terminal illnesses. Do we by now have our statistics right to know which particular age bracket has been able to access and benefit from this service?
Many thanks, Sophie. The sad reality is that the majority of those people that need palliative care are either out of employment as a result of their disease or retired. And it makes decision-making quite complex and difficult. And that's why Mark is lamenting about a policy for palliative care in Uganda. We have children. Actually, we have seen at Hospice Africa Uganda, we have seen about over 350, over 30,000. And when I talk about 30,000 palliative care patients, because Dr. Manga said that the center of our care is the patient, and our ultimate goal is to improve the quality of, of life for that patient. So we don't believe in seeing so many patients, but we believe in seeing a patient in totality or holistically, give all the services that that patient requires. The psychosocial, the physical, the spiritual. It is a total package. So we see so many adults that are in retirement age. We see so many adults that are in working, maybe in a working age bracket, but because of their illness, they are probably maybe out of employment, either retired because of their ill health or on leave as a result of being sick. So that's where the challenge is. So we are trying as much as possible to populate the data that we require to inform the world. We have data, yes. Like Mark has said, PICAO is trying as much as possible to make sure that they fund training. And training has a component of research. We at Hospice Africa Uganda, we have an institute that offers programs ranging from certificates, a diploma program, a degree program, a postgraduate diplomas, actually, several postgraduate diplomas, pediatrics, clinical, psychosocial, and a master's degree. And these are in affiliation with Makerere University. So we offer degrees that are for Makerere University. And that has attracted so many people to come to us. Unfortunately, the people, the majority of people that have embraced our programs are actually international people. People coming from elsewhere. It is of recent that PICAO has come in to support training. But because of the policy that has not been passed, many health workers don't take it as, as a line of specialization to take. Although we are seeing so many coming on board. And now that we have got a commissioner at the Ministry of Health level, we've got PICAO supporting training with all their might, supporting research. So we are trying to create data to inform the world. Literature says that we have about 1% of the population that are in need of palliative care. But that is an understatement. If you look at the patients that we see, majority of them don't even have access to health facilities. There are so many patients that are suffering with cancer and other chronic illnesses or life-threatening illnesses, but they never get a chance to reach a health worker. So all those are not being included in the statistics we are talking about today. So we need to do a lot more. We need to encourage more health workers to come for training, even those that have myths and misconceptions, because we have had it as a challenge before. We have a mighty medicine that is called morphine, or liquid morphine. It has done wonders. We've had testimonies from patients. We've had literature that testifies that this medicine is doing wonders. But you find that there are some health workers who were trained anciently or in the ancient days, having some bit of, I don't know whether, I don't want to call it negativity, but misconceptions about morphine use. I'm happy to note that as we speak now, things are getting to normalize.
Okay.
Very many people are embracing palliative care. Very many people are embracing morphine use. And very many people are coming for training. Before, we were training about 80% of the students that we were having at the institute were coming from Kenya, Malawi, and other parts of Africa. We've trained as far as Nigeria and from as far as South Africa. And we have had a few people from Europe coming for our programs. But it's because they have learned the usefulness of palliative care. So that's why the Palliative Care Day has come up. We are here to advocate for that, for palliative care. People who don't know palliative care, we are an organization, or we are a specialty that is there to answer the questions of those that are having terminal illnesses and illnesses that incapacitate them. Before, we had people think that palliative care is for those that are going to die.
Oh, yes.
That is wrong. Palliative care is for somebody with a disease that limits their life. We have people with sickle cell disease, like Dr. Mwanga has put it. They all need palliative care. They come with excruciating pain. We need to give them support. We have people with diabetes. They need palliative care. We have people with cancer. They need palliative care. We have people with HIV. They need palliative care, and so many others. So palliative care is not only for those with cancer. It's not only for those that are going to die, and it is not for euthanasia. In other words, palliative care does not cause death, like people had it before. They had that misconception that when you go for palliative care, you've been prescribed
to die,
a death, maybe warrant.
Or you've signed your death.
You have signed your death certificate, but it's not the reality. That is not true. So we are calling upon people to come and learn from us. PICAO is here. They have a lot of resources for people to learn from. We have Hospice Africa Uganda in Makindye. We have a lot of resources under the institute, which trains people from all corners of the world. Now we have introduced a short course that called the Home Care Giver. for people who are offering care to the patient. You know, we have before had challenges. Somebody is discharged from the hospital and is asked to go home. But when they go home, the family fears them. When they go home, there is carer fatigue. So we are trying to train these carers in a way that will support them. Because Dr. Mwanga has given you the definition of palliative care. The center of our care is the patient, but a family is also key. So we look at the patient, we consider the patient's priorities, but the family is also key. Because we have had people get into trouble. Families have disintegrated because somebody is sick with cancer, somebody is sick with HIV, somebody is sick with any other debilitating disease. So we care for the patient and the family. So if we don't support this family to care for this patient, we are going to get into trouble. We have helped patients to write wills. We have helped families to come to terms. Because somebody is dying or somebody has died, there is disarray in the family. And palliative care does not only end at the level when the patient dies. It continues. We give bereavement support even after the patient has died. So we bring the family together. We support families to come together. We request family members who can afford to support the education of the child or of the children that have been left behind by the deceased. So in other words, it is holistic. But people thought palliative care was just looking after somebody who is going to die, and when somebody dies, we walk away. It's not the case. So we are calling upon the government
of training.
Yes, we are calling
and
upon
I'm glad
government.
you have given it in depth.
Yes, we are calling upon government to support training of health workers. All health workers who are within patient care should be able to have at least some bit of knowledge about palliative care, so that we don't have to get somebody with a master's degree or somebody with a bachelor's degree to go and give care in each and every facility. We may not be able to afford that. But if somebody is grounded in offering palliative care at their level, then palliative care will reach each and everybody that is in need in Uganda and in Africa.
Okay, thank you so much.
You're welcome.
Now I'd like to get to Christine. National Medical Stores. What is your role when it comes to this particular aspect and subject or component of palliative care?
Thank you, Sophie. Good evening, viewers, once again. Just before I get into that, I just want to re-echo what National Medical Stores is. National Medical Stores is a government agency. It was incorporated by Act of Parliament 1993 and mandated to procure, store and distribute essential medicines and health supplies to the public health facilities primarily. So when it comes to palliative care, National Medical Stores deals with essential medicines, as I said. And as mentioned by Doctor, we do have the aspect of medicines that is needed to take care of that pain that really comes with these conditions. So as National Medical Stores, we do procure, store and distribute, especially oral morphine. That is one of the major components in pain management in palliative care. In 2011, there was a public-private partnership that was undertaken, whereby the government of Uganda provided funds for the procurement of oral morphine through NMS. This funds was given to National Medical Stores. And as National Medical Stores, we then contracted Hospice Africa Uganda, who was the pioneer in production of oral morphine in Uganda. So we contract Hospice Africa Uganda to manufacture this oral morphine. And when Hospice Africa manufactures, NMS then gets it and then supplies it to the public health facilities as well as the private and private not-for-profit. Oral morphine is free of charge to all patients who are entitled to it in Uganda. So for the public health facilities, National Medical Stores distributes it directly to them. And then for the private and the PNFPs, it's distributed through Joint Medical Stores, and then Hospice Africa Uganda. So we are in the aspect of essential medicines that is used in the management of palliative care.
Mm-hmm. Now, talking about it, there are times where don't you get to a situation where you face drug stock out, that specific magic or wonder drug, should I say? What happens when you get into a drug stock out as National Medical Stores?
As I talk now, we haven't had actually a challenge with the oral morphine. It has been readily available. Through PICAO, there are health facilities that are accredited to receive and administer the oral morphine. It's not going to all the public health facilities. We do serve over 3,000 public health facilities, but out of this, even as Mark has indicated, palliative care is in about 40 districts only in Uganda. That means that there are few of these facilities that are administering oral morphine and who are trained to manage it. So we haven't had that challenge of, stockouts of oral morphine. One of our biggest consumer of oral morphine is Uganda Cancer Institute, and they do quite get their stock without any challenge. And then we do also have Chirudu, National Referral Hospital, and the regional referral hospitals, and a few of the health center force and general hospitals who have palliative care trained nurses and departments that are handling. So we haven't had that challenge of stockouts. Okay, we actually sometimes had returns of the the commodity, because they don't have the people maybe to administer them.
Okay, that's good. Now I get back to Dr. Mwanga. What is the plan to ensure that the other districts that don't have these services can be able to have the palliative care services as soon as possible? Because there must be maybe a reason as to why we're still in those specific districts and some of maybe the far-reaching districts haven't yet got these services.
Ideally, what we did is all the regional referral hospitals, because in every region there's a regional referral hospital. So we have ensured that all regional referral hospitals have hospice services there. And the National Referral Hospital also has the hospice services there. So we are now trying to see that for the few regional referral hospitals, because there are some regional referral hospitals which have many districts, you find that there are some districts which are far away from the regional referral hospitals. So we are also scaling down to ensure that the general hospitals as well as health center force have. Ideally, from the ministry, the Director General ordered all hospitals to have at least a point of palliative care. You don't need a department as per se. You can work with integration within other departments. So what you do, provided you have a person who prescribes morphine, a staff who has a talent in palliative care, then the morphine, we already have enough morphine to supply the whole entire country, including the private services. So we're also using the private institutions to ensure that those areas which don't have the public services, the private institutions can also provide palliative care. The good part of it is, even in the private services, we offer the morphine free of charge. So those hospitals which are private can also access morphine through joint medical stores. And the ones which are public can get the morphine from national medical stores. So we're using the private and public partnership as well to ensure that we reach the hard-to-reach areas as well as those which don't have the real public services. So we're encouraging staffs. Now what we are doing, we are orienting a short course for some staffs in some departments to ensure that at least we have somebody who has a knowledge of palliative care, because you need a prescriber. If you don't have a prescriber, then you can't have the liquid morphine. So that one, we are trying to scale it up to ensure that our staffs can, our patients can access morphine. Then we're also trying to create a lot of awareness, because people have the myths. You find that we still have some districts which totally don't have palliative care. They are quite far, the staffs are few, And the majority of our people are still using the traditional attendance. Many of the patients who need palliative care don't access it. So we are trying to educate, to give people awareness. There are some areas, despite that the palliative care services are there, even people don't go there because they still have that means that the illness I got probably it is a curse from God, it is traditional. So we are trying to create a lot of awareness in the public. We're also creating awareness in the politicians, the policy makers, because the policy makers can guide right away from the districts, right away from the politicians. We're engaging the member of parliaments to ensure that their areas, people are aware about palliative care. Palliative care is not for only the people who are terminal, it is all people who have chronic illnesses. They need to be given a quality of life. So that knowledge which we are trying to promote, I think can enable the population to access these services.
Okay. Now, I'm meant to understand that there is a policy you came up with where it's now palliative care is a course unit in the medical school.
Yes.
But why is it that much as it's a course unit, yes, somebody will do the course unit, and I've even met some who have excelled as far as this course unit is concerned, but they don't go actually out to practice it. They'll pick on other areas of interest. Why do you think that is turning out that way?
I think now we are encouraging all training institutions, right away from the nurses, the clinic officers, the doctors, even the master's level, the pharmacists, palliative care as part and parcel. We have incorporated in a curriculum of palliative care within all those training institutions. But now we found that many of these people do it early enough in the course of their years, and very few of them rotate into these departments. For reason being that many of the hospitals didn't have the palliative care services. So we are trying to work hand in hand with the hospices such that our students can rotate, because hospices really have talented people who have the touch at hand. So we are rotating many of our medical students, the nurses, into these palliative care services to ensure that they get the skills. But initially they were doing the course early enough, so by the time they graduate and come back into the field, we found that they were not using that palliative care services. But we found that when they come into practice, you find that these people have found this course very relevant, because when you have a person who have chronic illnesses, especially those who are almost dying, one of the challenges we have got is many of our specialists, the doctors, the nurses, they fear to pass on bad news. A person has a terminal illness, the illness, she will not get better. So many of our specialists fear to communicate bad news. And ideally, we have found that many of our high-level officers telling them that this is a terminal illness you may pass on, it is something which has been a bit of a challenge. And many have even been taken abroad for the mere fact that people, instead of staying within their country, staying with their families, having that last moment with their families and enjoying the last bit of their life and being given the quality of life, we find that we send our people outside the country, and I think they don't get that proper palliative care of staying with their families. So we are advocating to ensure that we ensure that our people get the quality of life. You know, where the quality of life means the depth of life. You enjoy your last days. You know that this person has a terminal illness. Whether you take this person abroad, he may not get better. It's just a lot of money is being spent. The family can't access that. So palliative care is something we are promoting to ensure that these people stay with their people. They make the best wishes with their people. They laugh with their people. They write their best wills. I think this is something we're trying to promote in one way or another. So we have a policy, a national palliative care policy, which is soon coming out. But we had a drawback because we had to have a regulatory impact assessment whereby the policy analyst asked us, is palliative care policy the best alternative? But I think after carrying out that assessment, we found out that we need really palliative care policy. For reason being that if you don't have a policy, the guidelines to guide our staffs, the guidelines to guide the legal, because there's a lot of legal implications in the terminally ill people. So we need a policy to have it done. So my division and the Ministry of Health, with our top management, we are working very hard to ensure that that policy is out.
Okay, that's fantastic. Now, Mark, in terms of ensuring that every area is covered and you have at least an association there, you have a hospice there, what is the plan? How are you helping them to roll out? Because I know, and at least I believe, that some of those areas deep down there are the most affected. Possibly we're even speaking to them, or they have never even heard of it. How do you plan to reach out to them?
Yeah, thank you so much. And grateful to be with the panelists again and listening carefully about the promises again that our commissioner is giving. As an association, our biggest role is actually to advocate, to call upon government to provide this. The Uganda Human Rights Commission in 2017 actually detailed the right to palliative care and made recommendations, 9 of them. And among the 9, the key one was that palliative care should be scaled down to people, to the people who need it. As an association, we can do as much because we are civil society, but government has a role to provide the service because we pay for this service, and they have a duty to make sure that we reach. But this is what we are doing. We have worked closely with the ministry. Even as we plan the World Hospice and Palliative Care Day this Saturday, when we'll be having a national palliative care walk, we are in tandem. We are moving step by step with the Ministry of Health as civil society. We have encouraged all standalone hospices in the country, and by that I mean organizations that are non-state but with a compassionate service such as palliative care, to work closely with the regional referral hospitals and also with the general hospitals. So you will go to a place like Arua, and people are watching there right now. You'll find an organization supported by the Palliative Care Association of Uganda called New Life Hospice, Arua. They are working with the Arua Regional Referral Hospital. The hospital will actually discharge its patients through the New Life Hospice. The uniqueness about this approach is that Hospice Africa Uganda is able to go home to see the patient, yet the regional referral hospital, you have to come to the hospital when you are sick. True. Which is problematic. We have also been advocating for it, but as we advocate, we also support in a way. So, because the government is not going home by home or doing home care, which is very essential into palliative care service delivery, we encourage hospices to work hand in hand with the hospitals which are public. The other thing is that, as NMS Christine has explained from National Medical Stores, by the way, National Medical Stores is doing an excellent job. As you have heard, we've not run out of oral liquid morphine. Even during the pandemic, when everybody was closed down, there was even a bad story written by one of the medias saying the country is intending to have a closed down and a lack of oral liquid morphine. It never happened, because gradually the supply chain for medicines has improved in this country, and we applaud National Medical Stores for that, and we ask for more that people should actually access better. So we have worked with the joint medical stores, which is also private, and the National Medical Stores has accepted that model. So they provide in bulk, and JMS actually goes to facilities and offers for free. That's a contribution that I think is also very important, that the private actors correspond or work together with government actors to make sure that the service is provided. I can also mention that we are doing our best to reach communities and to do the advocacy and the awareness. In our strategic plan, which we have rolled out now, we want to go to all district council halls and speak to the councillors and people who make decisions at that decentralization level. They have a role to play. We have been speaking to DHOs. Actually, during COVID, interestingly, we wrote a statement through the National Task Force for COVID up to the President, and the President, on one of those amazing addresses, said palliative care should be handled by district health officers. But some of the district health officers did not heed quickly. So we want to go back and advocate and speak to some of the DHOs listening to us. The directive of the President is still there, that they should know the sick people within the district and actually do something. As Dr. Mwanga was saying, sometimes our organization, the Palliative Care Association of Uganda, has offered scholarships. And it takes a great deal of resources to train somebody to get a diploma. Somebody goes back to the district, is deployed in a general hospital, and is not allocated space at all. And when you go for support supervision, and this time with the Ministry of Health, you find a very demotivated health worker. Somebody who has spent 9 months in 2 specialized training, not offering the service. So we have been knocking at DHO's office, we have been knocking at the Ministry of Health office, saying we need to see the people trained doing what they should do. And perhaps this TV is watched by even government actors, the public service, for example. The trained palliative care specialists needs recognition on remuneration, on recruitment, on retention within their specialty. We have had promises by permanent secretaries from Ministry of Health, from public service. We need to see the reality of the public service structure of the health workforce, including a palliative care specialty. Because, as we have already said, and as reality is, palliative care is everybody's business.
True.
Today, we are on TV speaking about this, but we are speaking to multitudes of patients who perhaps are looking at us and thinking, those people don't know this pain that we have now. They are just on TV speaking. As the National Association, our offices are in Ichitende. Nearly in a month, we'll get somebody who just branches off and comes and tells me directly or speaks to the staff and says, you are just here speaking. You are just, the pain, as you said, is in the community. So we can do the speaking, but we need to do more of the actions. And we need to see government doing more. I can stop there on that, but we need to see more action. And as an association, we are doing as much as we can. That's why, for all our resources, as the academic registrar from the institute has said, we have said our biggest budget goes to health workers for training. That's as much as we can do, but it's not enough. The government should also put aside some support for health workers to train. So whatever we are doing in partnership with government, we advocate for more. Lastly, there is a lot of need for other professionals, for other stakeholders into this service. This week has enabled us to speak to spiritual leaders. You know, sometimes the spiritual leaders do not utilize the opportunity that they should. In our culture and in our way of things here, they come to burial, for the burial sometimes. And actually some spiritual leaders or some of our community, they won't bury unless a spiritual leader is physically present. So they have that respect. But do you know some of them do not actually offer the palliative care? They do not even come to join the palliative care team to offer the spiritual care. And majority of the patients are asking themselves, why me? Did I do anything bad to God? So we have been appealing to the spiritual leaders. They have a role to play. The political leader, they have a role to play. The opinion leader, they have a role to play. Some spiritual leaders like Mothers Union, they have a role to play. The sheikhs, the imams, the pastors, we have been doing that, and we intend to continue doing that. So that's one of the ways, like, we are doing this to make sure that the districts that don't have are reached, but we appeal to government to do more. Thank you so much.
Okay. Now I'll get to you, Dr. Desor. You talked very passionately about the issue of having scholarships, about training, and then the trainings are more utilized by people, external people, as opposed to your own here. In your training opportunities, have you thought about, or do you have plans to train the VHTs? Because I believe they're much more closer to the communities and will possibly even easily identify which household has a person that needs the palliative care services.
Thank you so much, Sophie. In that regard, Hospice Africa Uganda as an organization has foreseen all the things. We have a program that trains village health teams. We have a program that trains volunteers right from the grassroots. And these are people who identify patients for us. Actually, the biggest referrals or number of patients we receive from the community or from communities are actually referred by that group. So we've trained several people to identify patients from communities and to give basic care at that level. So for that, we have tried our level best. And I would like to applaud a lady that gave birth to palliative care in Uganda. Dr. Mwanga has talked about her. Professor Dr. Anne Merriman. She's so passionate about palliative care. She came with palliative care here in Uganda. She keeps telling us that Dr. Makumbi, who was the Minister of Health by that time, allowed her to come with morphine to Uganda. And I would like to applaud her for passionately making sure that palliative care continues. I would like to applaud the Ministry of Health. Ministry of Health has done a lot. You've heard very well that we don't have a policy for palliative care in Uganda, but we are leading. If we can have a commissioner for palliative care at the Ministry of Health level without a policy, supposing that policy is passed, what do you think will happen? You asked a question about, Dr. Mwanga answered it, about health workers not taking up specialties in palliative care. Partly it's because the policy does not prescribe anything for them. If there is no line of appointment, there is no line of career development prescribed by policies on the ground, it becomes a little bit of a challenge. That's why we are finding it difficult to attract the numbers that we want to attract. Much as we are attracting, but we're not attracting the numbers of health workers to train as much as we would have attracted. PICAO has tried their level best. They have gone to the communities, they have gone to districts to identify trainees or health workers that are suitable for training. It is one of the challenges that we are receiving because the policy has not prescribed anything in the scheme of service. They are not clear. There are no clear lines or roles for palliative care service providers. They get deployed to other areas. But I'm happy to note that of recent, government has started deploying health workers specifically to offer palliative care. That is light at the end of the tunnel. I would like to applaud government, to thank government for providing the resources to procure the morphine powder. Without resources from government, we would not be speaking about anything here. So the government of Uganda has done a lot. And I would like to applaud NMS for making sure that they coordinate this role of making sure that the powder is not out of stock, for making sure that Hospice Africa Uganda, which holds the contract to manufacture this morphine, continues providing that service to the country without necessarily having stockouts. That is a very big thing that government is doing. Very many countries here are admiring what we are doing, much as we still want more. But they are admiring what our government has been able to do in as far as palliative care is concerned. But Mark has rightly put it, we still need more. We need a policy in place. We need funding for our health workers to train. We need so many things. Now, okay, we have doctors that have chosen to specialize in palliative care. They are on their master's program. We have the first cohort of a master's group that are doing specialization in palliative care at master's level. So those people that have chosen to come for palliative care need to be guided where they will be working. They need to be placed and they need to be recognized. So that's what we are calling government to do for us. Let us expedite the process of passing the policy so that everything is streamlined. So we are trying our level best, but without support from government or further support from government, we will stop at this level, asking our colleagues to come and join us in the battle. But they are like, where are you taking us? So that's the challenge that we are receiving. Very many people have come, they have trained, and they have put their certificates in the case, or in the suitcases, and they have gone back to the primal
medicine
specialty, or profession. So we train nurses, clinical officers. Actually, the nurses we train are actually at the level of registration or registered nurses and above, doctors and clinical officers in palliative care. These people are grounded. There are so many people that are interested in palliative care. I coordinate the admissions of students every year. We receive so many applicants that are coming from Ugandans, but because of support that they don't see coming to their side, they complain that the salary is not enough to support their training. They complain that when they finish their training, they will not be, recognized. They complain that when they want to offer services to the community, they are asked to go, and if they were originally nurses, they want to go and give their demonstrators want them to go back and do the previous role. Mm-hmm. So that one sort of demotivates. So we are calling upon government to make sure that they help us to pass the new policy for palliative care. And that will be the turning point for palliative care in Uganda.
Dr. Mwanga has heard you. He will respond to that.
Yes, Dr. Mwanga is very supportive. I am very, very sure that with his coming, everything is going to happen. And with the support of Pikau, I have to thank Mark for the role he has played, spearheading palliative care services as an organization or as an association, because they are coordinating each and every activity that we are seeing in Uganda. People are admiring. We have so many people that are coming from elsewhere to come and learn from us. We have people from West Africa. Recently at Hospice Africa Uganda, we had pharmacists, a group of pharmacists that came from Senegal, from those French-speaking countries. They came here specifically to learn from us, because Uganda is one of the countries that is doing a big role, or performing miracles in palliative care.
Okay, that's
with the support of the African Palliative Care Association. We're happy to note that that association has their headquarters in Uganda. So that is also a privilege. The African Palliative Care Association is in Uganda. Their headquarters is in Uganda. So we are in a way advantaged. And the Pearl of Africa is still,
we shall
Uganda
get
still
there.
remains the Pearl of Africa. So we are requesting that everybody that can support palliative care, because you've heard very well that morphine is a free medicine that is procured by government, given to Hospice Africa Uganda for reconstitution of turning into what you see in the bottle, and distributed to patients free of charge. But we've had challenges with patients not being able to come to seek the service. They cannot access the service. Majority of the patients that we are seeing as Hospice Africa Uganda are actually being seen from their homes. But we've been depending on donors. And with the coming of COVID and a few other challenges, donors are getting tired. Majority of them have actually died because of COVID-19. And COVID itself has created a challenge. You remember when the president was addressing the nation during COVID, one of the issues he talked about was palliative care. He instructed DHOs to make sure that palliative care is offered. Some people didn't know the usefulness of palliative care until COVID came into the equation. They discovered that people were getting psychosocial issues which needed answers from palliative care. We had, we had people that were behaving abnormally, patients that were behaving abnormally, survivors were behaving abnormally. The story is a long one. If it were not for time, we would speak on it.
Okay, now Christine, a lot of beautiful things have been said about National Medical Stores, and would like to applaud you for the successful distribution of oral morphine, and you've made sure that there is no stock out as far as that area is concerned, but there is still demand for more. How does National Medical Stores plan to come in, like you see the issues of support and training and here and there? Do you have that in your plan? Or we are going to strictly stick to the distribution of and ensure that the oral morphine is available in our facilities?
Thank you, Sophie, for that question. I would say, our motto is passionate about your life. So even as we are here, we are sponsoring this so that there's awareness that is created, sensitization, advocacy, and as this is being done, we are hearing the voices. So as National Medical Store, we may not per se saying that we'll contribute to the training, because we do have an activity to do, a mandate, but we go ahead and see how we can partner with the other stakeholders and even through the voices that we are hearing here, we believe that we can have, Ministry of Health is talking of policies of integrating this into the curricula. So as these are developed, we believe that we would have contributed not directly but indirectly to the funding of
Then
training.
what is going to be your role come Saturday? Are you going to participate in the activities as National Medical Stores, flying the flag high as we get down to enjoy and commemorate this wonderful day?
Yeah, we are partners in all this, so we'll be present, we'll represent, and we'll participate in the activity, even as we fly the flag of palliative care and hospice services.
Dr. Mwanga, I would like us to get into that actual day now. I guess it's a lined up list of activities. What should the public expect come Saturday?
Ideally on Saturday, we expect the public to come and get more information about palliative care. We need a lot of advocacy. We need to give people updates of what is happening within the palliative care fraternity. Then we are going to share some of the lessons learned by different palliative care departments in the different regions. I think as a ministry, we are really proud because I think this year has been really nice for palliative care. We had a conference of the African Palliative Care Conference within Uganda. We are now celebrating the palliative care day and hospice. I think we really feel proud that awareness is now coming up. People who used to have a lot of myths about palliative care, they are now understanding that palliative care is more than just waiting for a person to die, but how do you make that quality of life for that person happier? We have people who have benefited, survivors of the chronic illness. I think they're going to share with us the experience of what role can each one play. Each one of us, I think, has a role to play, because whether you're a caretaker, a family member, a spiritual leader, there's a role you can play. You can give that person hope. So I think our celebration basically is to call everybody to come on board, the policy makers, the leaders. There's something you can play. You can give a person hope. You can give happiness to that person who is suffering. And again, we are trying to create awareness such that the myths which people had comes out of the people. COVID, I think, gave us a lot of lessons learned, because COVID season, I think many people, initially, I think we thought of the first departments we closed and the mental health departments, without knowing that the people who are going to suffer from COVID will end up with mental illness. So again, we had to reopen those departments and bring in the departments we had closed and bring in palliative care. And I think our staffs who have trained in palliative care have a different touch, because they treat a person, the person is in the center of the management. There's holistic management into that. You don't look at the illness of into the person, but look at that person holistically. I think on the 8th, we are calling upon everybody, come and join us. We are going to walk. We are going to have that walk with all categories of people who are in need of palliative care, people who are supporting palliative care. I think we need to give them a lot of information onto that.
Okay, thank you.
Please join us.
We just have like 5 minutes to the top of the hour. Mark, I beg for you to sum it up in 2 minutes. Where is this going to take place and who is the chief guest? You might also want to tip us into a bit of why you chose her in just like a minute or two.
Thank you so much, Sophie, and for the opportunity to again mention that the World Hospice and Palliative Care Day globally will be commemorated on the 8th of October 2022. The 8th is the day before independence. So this is the Independence World Hospice and Palliative Care Day. And as Nasuli has said, we have a lot to celebrate, even as we talk about our independence. Our palliative care service has grown. So come along. All you need to do is to show up at the Mulago Hospital Playground. It's just near Taso, just near MJAB. We're going to do a 4-kilometer walk in the morning starting at 7 a.m. And then the members of parliament will come and play football with the palliative care providers. and they have confirmed. We invited the Speaker of Parliament specifically because we want the legislative arm of government to be at the forefront of this service that we're talking about, because they mean a lot to their constituencies. So people who are watching us, you don't need to do much. We have been selling kits. Actually, they are sold out. People have bought up the T-shirts, but we'll have some T-shirts for people who come to work. Come Saturday, just come up so early. Join us. We have the police. Security will be very tough on that day, but you don't have to fear security. They will check you, and then we will work together with the members of Parliament on that day. And we hope to pass on the message and information, as Dr. Mwanga said. Tomorrow in the evening, we'll have a Twitter space, and we'll be talking about access to medicines in a detailed manner. So you can look forward to join us about that, and the other services and issues are on our Twitter space, on our website, on our toll-free line. And thank you so much, even for UBC and NMS, for giving us this opportunity to speak to the public.
Okay, thank you so much. You've been such a wonderful panel. And thank you so much, the viewer out there who's been watching into this show. I believe you have learned or gotten a lot to learn from. Right now, I'd like to hand you over to Studio B, where we are going to take you into the 10 o'clock news with Edward Chija Ngoma, who will be coming your way shortly. Have a very good night. Thank you so much.
To persons suffering due to severe illness to improve their quality of life and their families. The World Hospice and Palliative Care